your state table card is. So I'm from the state of Georgia. I'd find my table that says Georgia and sit there, okay? Because then we're going to do our team meetings. We're going to hear from Soapbox, who's helping facilitate the meetings, kind of run through all the logistical stuff. And then we'll have lunch. We're going to split this room in two, and then we're going to have first-time people here at the Hill on one side. That's going to be on that side of the room, room 8. And people who have been here before, and the team leaders, is going to be on this side. So we'll have different content, and then the up-and-coming youth, so that would be 19 and below, are going to be upstairs in room number 4, and I'm going to lead that meeting. We're going to talk about developing a youth track here, which is going to be incredible. And then we're going to have free time from 2:30 to 5, and then we're going to meet and have fun tonight. So without further ado, we'll go over some of these things later, but come up, Jason, and give us the state of affairs on the Hill.
Thank you, Kelly, and thank you everyone for being here. I have no slides, so not a slide guy in this sense. But I think how I would describe the current state right now, and I'll take a step back in a second. The House has been meeting, you may have seen this on the news or wherever you get your news from. They've been going through a bill that is called reconciliation. So a couple different versions of what will be a large bill in different committees of jurisdiction. And you're going in to meet with folks tomorrow that have been up really late the last week, including last night where actually some of the committees finally voted. So I just say that to say the typical advice is always be patient, be flexible, and I think that's sort of even more true this week. With that said, remembering why you're going up there is, of course, the most important thing. And I know the entire agenda looks great. You have experts here to talk through it, and you're going to be able to sort of shape your stories into those asks. But if we were to take a step back, I remember when it was the 100th day of this administration, and it felt like it had been a little bit longer, let's say that. So we're a couple weeks past that, but a lot has happened. I think we all know that. You can see that, whether that's on Capitol Hill in Congress, or things going on within the executive branch in terms of the NIH, right? Different research institutions, different changes going on. Of course, we've heard a lot about cuts to research. We've heard about, notably in the last few weeks, cuts to the Medicaid program, which I think everyone here and all the organizations that are working on behalf of folks living with chronic disease disabilities are really concerned about, and I think that's extremely valid. And so with all of these sort of changes, I would just say staffers have heard from all of our groups in the last 2 months. They've met with folks, so go into it knowing that for the most part, right, they're going to be excited also, I think, to talk about something a little bit different. So I know some of the legislative asks, I think that's a really positive thing, and I'm hoping that we've sort of hit a bit of a stall as Congress has been moving through this, what they've done, reconciliation, which the best way I try to think about that is just an expedited process to pass a budget, which we have a lot of difficulty here in DC doing each year. But so they've been really focused on that. Again, a lot of late nights, especially the last week or two. But now I think is really, really good timing that you and the CSD are here, because I think we can start to turn some of the wheels on some of the other really important issues that our communities want to get done. And so, with that, that's kind of like the ethos I'd say we're walking into tomorrow. I think there's a lot of positives to that, again, but just know that you might see, right, there might be a bunch of people there tomorrow, there might be a protest or two, or sort of folks walking in the halls, and I would say just expect that. It's nothing that doesn't happen all the time, but some of these issues have gotten really contentious, and I think you've probably seen that in the news. And I think our advice is always, there's 100 different issues out there that all of us probably want to see get done. But the reason you're here today, tomorrow, are the issues that are here, and you're here for your community and yourself and your loved ones. And I think that is, that's the North Star is remembering why you're here. And if there are other things that happen, you can talk about those or do those later as well. So happy to take any questions. I wanted this to be pretty quick, but I think that's kind of what it is. And I'm really excited because I think it really is the better time to be up there right now. And the last thing I will say is the House is expected to vote on this large reconciliation bill that includes quite literally thousands of pages on Thursday. So I think that's going to be on the top of minds of a lot of people. And so, in your meetings, if you hear that, you'll be able to know that. And the last thing, really the last thing, is within that bill, there are things that we'd all be concerned about. I don't want to run through those all now just because it's maybe too long of a list and it's a little distracting in that sense, but there's also some things that I know related to PBM reform, which I know will be discussed later, pharmacy benefit managers, that is in it right now. So I'm just flagging that as, as you're going through that, you'll probably hear, oh, well, this is in the reconciliation bill. And so that's kind of it.
Thank you, Jason. Many mics. So next I want to welcome Natalie to the stage. A lot of you have been hearing from her and Becky. She is our amazing communications manager, and she's just done such an amazing job helping put this whole show together. So Natalie is going to take us into our policy issues. I don't know if you want to stand down here or up, but you know how to use this stuff here, right?
Good morning, everyone. Good morning. How are you? Good. I'm happy to be here. As Kelly said, I'm Natalie with the CSD, and I am a patient advocate myself. I have alopecia universalis, so shout out to NAF and all my alopecia folks in here. I want to go over our overview of legislative asks, and they're sort of chunked into two areas. I'm going to talk about the first sort of half, which is the funding piece. So every year Congress has 12 funding bills that they have to pass by the start of the fiscal year, which is October 1st. And that's called the appropriations process. It's sort of a fancy word, but it just means funding. Congress has the power of the purse. And so we want to focus on asking Congress, asking your members of Congress to support robust funding for the National Institutes of Health and the National Institute of Arthritis and Musculoskeletal and Skin Diseases. Congress is just starting the appropriations process. It typically happens May, June, and then the goal is to have it passed before October 1st. It doesn't always happen. That's when you hear that funny term, continuing resolution, or CR, but we're not going to worry about that. The bottom line is the appropriations process is literally beginning right now. We are at the perfect time to talk about funding. So you want to ask your member of Congress to support robust NIH funding. So there are all sorts of facts and figures that you have access to. We are going to have a talking points document in the folders that you will take with you on the Hill. And there's, I always say there's more than 84 million people, or a quarter of all Americans, that have a skin disease. That's a huge number, and a lot of members of Congress don't know that. A lot of their staffers don't know that. And so some of what you're doing is educating them on, they might say, oh my gosh, I had no idea so many people have a skin disease. And so, what we want to say is a quarter of Americans have a skin disease, but the funding for that research is not matching the need. So please support NIH funding. The other one we want to talk about is robust CDC funding. So the Centers for Disease Control Prevention, and within that, the Chronic Disease Education and Awareness Program. And that one, chronic diseases account for 7 of the top 10 causes of death in America and more than 90% of our annual healthcare spending. So again, those are some numbers that you can use to back up your argument. I think the most important thing is to know that this is really good timing to be talking about this with your members of Congress, since the appropriations process is fresh in their mind and just starting. And I think with that, that's all I have on the funding portion.
That was really great. Thanks, Natalie.
Sure.
So next we're going to invite Rachel Klein, who's the Deputy Executive Director for the AIDS Institute. Rachel was with us a couple of years ago in our very first soft launch Hill Day, and she gave an overview of our next ask, which is on copay accumulator programs. This is one of those things that's like, what the heck is that? And I remember when she was done with her presentation, there were so many questions and people were so fired up when they realized what these things are and what's actually happening and how patients are suffering. She was literally walking backward out the door because she had something else to get to. But it was such an amazing discussion, and we're so happy that she was able to come back and educate us again on this. So thanks, Rachel. I'll let you take it away.
All right, thanks. Thanks. I think we also ran like an hour long in that session, so I'm going to try really hard for that not to happen today. So let me go ahead and jump into it. We're going to talk a little bit about the Health Copays Act and what is it, what is the problem it's trying to solve, why do we need to do it, and what can you do to help? Okay, so I think the very first thing to know is that healthcare is really expensive, right? And this is not news to anyone in this room. I am confident of that. And it's only been increasing, right? Getting more and more expensive. Copays are going up, deductibles are going up, and in general, out-of-pocket costs are kind of outrageous at this point, especially for people who have a chronic illness and interact a lot with the healthcare system. So, you know, we have some figures here about the average cost that people bear in a silver plan. And a silver plan is the sort of benchmark standard plan that people buy most in the health insurance marketplace if you're buying your own coverage. And so, you know, it's really important to know that these out-of-pocket costs are high and that most insurance plans have a specialty tier now in their cost sharing for prescription drugs, and that's always the highest tier with the most cost that patients have to bear. And a lot of times, this is not even a flat dollar amount. It is the percentage, it's a percentage of the list price of the drug, and it can be as much as 50% or even more in some cases of that list price of the drug. The list price, by the way, is not borne by anybody except for patients. So no one else in the healthcare system is paying anywhere near or anything based on list price of the drug. So this has caused a lot of people to go into medical debt. Medical debt is very, very serious in this country. People bearing thousands and thousands and thousands of dollars in medical debt, and it's more likely for people with chronic illness to be bearing this debt. And it has real consequences, right? People delay getting more care, they forego getting care altogether, and they have to make really hard choices about where their family is going to spend their money, right? Are you going to make the choice to pay your healthcare bills, or are you going to pay your mortgage, or are you going to buy groceries, or, you know, get the kids new shoes, or pay for college, whatever it is. And it can also have a very serious impact on your credit rating, which makes it really, really hard to do other basic things in this world. And so this is why this issue is such a big problem, because these costs are just too high and people can't afford them. So what do people do? People with chronic illness who rely on specialty drugs or high-cost brand name drugs often get copay assistance for their medications. Then that's usually given by either a charitable foundation or by a drug manufacturer. How many people here use copay assistance for some of your drugs? As see a lot of hands going up, right? My family is one of those families. My child has a prescription that they take regularly that is a specialty drug, and we rely on that copay assistance. So a few years ago, what happened is some of the health insurance companies decided that they're no longer going to count copay assistance when they're calculating whether you have made your annual deductible or your out-of-pocket limit on the cost of your health care. And that basically, for people who rely on these high-cost specialty medications and rely on copay assistance, means there's effectively no deductible limit and no out-of-pocket annual limit, because you can get your copay assistance, can pay and pay and pay until it's exhausted. And then, at that point, you might go to get your next refill, and guess what? You now owe everything that has already been paid to the insurer. And so that is why we have launched the Health Copays Act. So let me just digress for a second before I get too far into it. This QR code no longer works. I can send you guys a different one. But this does show the results of it. And if you go to our website, you can find at gatesinstitute.org the annual report that we do, looking at how many health insurance plans in every state in the marketplace have copay accumulators, or sometimes they're called maximizers, copay maximizer programs. They're effectively the same thing when it comes to the patient, right? Your copay assistance isn't being counted. And what we have found is that in almost all of the states, except for the ones listed in the A column and the A row, have plans in the marketplace that have copay accumulators or maximizers in them. So every state in the A group, except for Hawaii, has a state law that prohibits plans from using these copay accumulator policies. But you will notice that in the B and the C groups, there's little asterisks next to a group of states. Those states also have state laws that limit the use of copay accumulators. But what we found when we looked at the plans in those states is that those bans are not always being enforced. So some of the plans still have plan language that says that they have these policies in them, even though there's a state law that says that they shouldn't. And that's one of the reasons that we're looking for a federal law, right? Is because, you know, look at all of, we have 51 states plus Puerto Rico plus DC that all have health insurance plans, right? And all have different rules about what needs to be covered and what those costs are. And, you know, we shouldn't have protections in some states and not others, because, you know, we're all Americans, and no matter where you live, you should be able to afford the medication that you need when you have health insurance. So we have fact sheets for all of these states that are one-pagers that show, you know, whether your state has one of these laws or not, what the plans are that are in the marketplace in your state, and then whether or not they have a copay accumulator or a maximizer. And it's all on one sheet, and you can print that up, you know, if you want to take it with you to the Hill. Here's an example of some of the complicated language that plans use. It's really hard to know whether or not the health insurance plan that you want to purchase has a copay accumulator. A lot of times, it's just not like something that they advertise, right? It's not like at the top of the page that says, by the way, your copay system isn't going to count. Instead, they use this really convoluted language that you have to dig for, and sometimes we've had to call instead of just looking in the plan materials to find out. And they leave themselves a lot of wiggle room, right? So if you're checking your plan at home to see whether it has one of these policies, you're gonna have to dig for it. And it may have really complicated language that makes it really unclear, or says that they reserve the right to do it, or, you know, makes it unclear about whether it's for all specialty drugs or only some of them. But this is when we're looking for the plan language to decide whether or not a plan has copay accumulators. This is kind of some of the stuff we're dealing with. It has real implications for real people, and we have a lot of stories of people around the country who have been faced with a copay accumulator, and as a result have had to make really, really serious choices for their family. I want to draw your attention to David, who's down the third on the left here. David had to make the decision to move to a different state. And at the time that he was faced decided to move to Illinois because that was one of the early adopters of these laws that say that the plans shouldn't be using copay accumulators. Right now, people have more choices. There are, I think we're up to 24 states, plus DC, plus Puerto Rico, that have established one of these laws. But even then, as we just said, you got to make sure that you look at the fine print in your plan. So, you know, these are some of the examples that we've heard from people about some of the really, really serious implications of these policies. So, let's get to the part about what we do about it. As I said, 24 states and DC and Puerto Rico have laws that limit the use of this practice. And there are more states that are looking at their state law. And if you live in Rhode Island or Missouri or Ohio or another state where you know that there is a campaign afoot, you should feel free to jump in, right? There's going to be opportunities to lobby your state legislature to ask them to pass one of these state laws. State laws are great. They protect a lot of people when they're enforced, right? But the limit is that not all health insurance plans are within the jurisdiction of the state. Large employer plans are often not within a state's jurisdiction to regulate. So they get to regulate the marketplace and they get to regulate other individual and small group plans. But if you work for a big employer, which a lot of people do, then we're really relying on the federal government to pass a law that applies to all health insurance in the country to restrict this practice. And so we came up with the Health Copays Act. The Health Copays Act was introduced in both the House and the Senate last year. We garnered a lot of support for it in both the House and in the Senate. It is bipartisan. Both Democrats and Republicans support this legislation. And that's true in the states as well, right? In the states that have passed these laws, we've seen tremendous amount of bipartisan support, and you'll notice that they are red states, they are blue states, they are literally all over the map. And so no matter what office you're in on the Hill, you can be talking about this issue and ask them for their support. This year, because as Jason mentioned a minute ago, there's a lot going on in Congress, right? And they've been really, really distracted on a lot of other issues regarding this reconciliation bill and budget stuff. We've been able to get the bill introduced in the Senate, but not yet in the House. So one of the things that we are asking for is for more senators to co-sponsor this legislation. And in the House, we are asking members to talk to their leaders about this bill and to get a bill introduced, right? So that's kind of where we're at now in terms of what are you asking for. Some of the arguments that we hear from the other side, from the opposition, is that copay accumulators help keep premiums down and that passing this law would increase premiums. We've looked at the premiums in the states that have both plans with and without copay accumulators, and I'm going to tell you, there's very little difference, right? And in most cases, in most states, in health insurance premiums in this year, the plans that have copay accumulators have somewhat higher premiums than the plans that don't. So there's really no evidence that there's correlation between this provision and how much premiums cost. Premiums are set by a lot of different factors, and this policy just really isn't having a big impact on it. So what does the Health Copays Act do? Essentially, it has two provisions, right? Number one, it requires that all the copays paid by or on behalf of an enrollee are counted. Very simple, very straightforward. And that's true whether it's a nonprofit charitable foundation that's providing that assistance or a drug manufacturer. Number two, it clarifies that if a plan is covering prescription drugs, the out-of-pocket costs have to apply because prescription drugs are part of the essential health benefit package. And some plans are playing kind of squirrely games where they're saying, well, specialty drugs don't count. Well, that doesn't make any sense to me. You need a prescription for a specialty drug. If you need a prescription for anything, it's a specialty drug, right? So to me, that sounds like a prescription drug. So this basically says, if you cover prescription drugs in your plan, those out-of-pocket maximums have And you have to make the co-pays count for those as well. Okay, so that's basically what we are saying. That provision number 2 there talks about a little bit more detail about some of the things that we put into the bill to address some of the ways that insurers are getting around this question. We're basically saying that this provision applies to specialty drugs that are subject to utilization management, because all specialty drugs are subject to utilization management. That's like, prior authorization or step therapy, and to drugs that people are able to get access to because they've gone through these processes and their plan has said, in fact, this is the right drug for you, even if there's a generic available. These are the folks who are currently co-sponsoring this bill in the Senate. So if you're visiting any one of these folks, you're going to want to say thank you to them for co-sponsoring this bill. And if you're visiting anyone else in the Senate who's not on this list, ask them to co-sponsor. In the House, we know that it's going to be led by Representative Keene from New Hampshire and Representative Barragan from California. And so if you're visiting either of those guys, ask them please to get this bill introduced. And if you're visiting anybody else in the House, make sure that they know that this bill is coming and ask them to talk to these offices or to the leadership and make it come sooner. And these are some links to some resources that you can get off the internet, and my email address is there. I'm always happy to answer any questions about any of these issues, and I hope you have a great day on the Hill.
Thank you, Rachel. And we'll have time for questions if you're able to stay a little longer, Rachel. Okay,
I am.
That's wonderful. At the end of all of this, so I am going to invite Michelle Guadalupe next. She is the Director for Advocacy and Access for the National Eczema Association. She's been doing this work for a long, long time, and she's just an amazing individual. It's easier to come up this way unless you want to take a big step.
No, I don't want to.
But Michelle, I was thinking, as we were listening to Rachel, for some people who this is their very first time advocating on the Hill, could you give a little bit of background on what does it mean to be a sponsor? Why do we need a sponsor and a co-sponsor? What is introducing a piece of legislation, and why does that matter? Just to give some more background, because I know with these bills, they have been, something we've asked for in the past. Why do we need to reintroduce them again? So before you go into your piece, and here's the clicker to go to your slides, but could you give a little bit of explanation?
Yes. Hi, everyone. Yeah, this is interesting, the pillar. But maybe I'll move around a little bit to make sure that everybody sees me. Yeah, so I mean, there are thousands of bills that are introduced.
Is that on?
I don't know. Let's see.
Maybe
not.
Is that better?
Yes.
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 Okay.
Yep. We can hear
Awesome. So every session, which is 2 years, there's thousands of bills that do come out, and many times they don't get very far. So you really need to have, different legislators really champion each of these bills, and it's groups like us that really help that whole process. So in order for bills to be introduced, you need to have those original co-sponsors. A lot of stuff goes on behind the scenes. So many of our groups, we're in there, we're in the offices, we go in earlier than session starts, just really championing our different issues and the different bills. So it is good, because I can tell you that for step therapy, that I'll talk about in a minute, this last session, the number of co-sponsors that we had actually tipped over a little bit more than half of the entire Congress for House and Senate. So that's a great thing, but as Jason had talked about, as Rachel has talked about, there's a lot of noise on Capitol Hill. So that doesn't always ensure that your bill is going to hit over the finish line. It's a very good indication, though, when you have that type of number of co-sponsors. So what you guys are doing is you're talking about how do these bills impact you? If maybe you didn't have one of these issues impact you yet, how would it, with people that have skin conditions, if, would you be able to afford your medication if all of a sudden at the pharmacy counter you would be faced with thousands of dollars that you would have to pay? Most of us don't have that type of disposable income, so we know that we can advocate and say, hey, you know what, I'm not going to be able to get my medication if that's the point. And then these are the consequences. You can go through what can happen. So it is good for these bills that we're really into, that we go to as many, our legislators, we're the constituent, we go to them, get them to have that support so that we can kind of amp up those co-sponsors. Now in committees where you'll hear these bills, committee staff will look and see, well, what kind of support is for these different bills? That can help them decide whether or not they want to do markups. So have committees, have those conversations with the bills. So all of this great energy that we have in the room, all this that we take, the number of co-sponsors we get, it's a really great sign. So I hope that answered your question. There's a lot to it, but just know that there are so many folks here in Washington, D.C. on a daily basis, including many of them that are in the room. I live in Texas, so I can't go to the Hill as much as maybe some others, but just know that there's so many different patient groups. We're all in this together. We're representing 84 million. There are so many groups that are not here in the room that are also fighting for health co-pays, for NIH funding, for CDC, for what I'm going to talk about with Safe Step Act. We're really, truly in this together. Oops, all right, so I'm here to talk a little bit about step therapy reform. Now picture this, it's like the year probably 2013-ish. I was newly married. My husband he had psoriasis all his life. And he says to me, Michelle, I think something else is going on. I'm like, all right, let's figure this out. He was saying that he had some joint pain. So I was wearing, at the time, I worked for another organization, Arthritis Foundation. So I said, hey hubby, why don't we go and see a rheumatologist? So fast forward maybe a little bit, and my husband was diagnosed with psoriatic arthritis. So knowing that he wanted to have conversations with his healthcare provider, they wanted to figure out, what is my treatment plan going to look like? My husband, he didn't really want to go for the big medication right away. He said, let's try. What is your recommendation? What can we do about this? Not really knowing, but my husband went through step therapy because they were trying different medications to see what was going to work for him. Eventually, as many people do, he needed to go to another type of a treatment. And luckily for him, he was able to get on that medication because his doctor was able to show that he had tried many different medications, he failed those medications, now we get to do this. So my husband's story was probably pretty typical of many people that go through medication. What is not typical and what's not right is when many of us, we've tried and failed, we've done all of that, and then we're faced with some of these issues. So what is step therapy? Kind of talking about this a little bit, really, when you're thinking about kind of just my husband's story, that's just one. But it is when you're required to try and fail, it's usually insurance preferred treatments first before they will cover what your prescriber initially wanted you to try. And we've really found, and all of our research shows, that it really needs to be that decision made between the patient and the healthcare provider. So, we wanted to do something about it. Now I said 2013, working with, my husband had his issue, I was working for a patient advocacy organization. Safe Step Act actually was first introduced in 2017, but some of the states, we were working on step therapy reform a little bit earlier than that. We knew that patients were coming to us saying that, hey, I'm running into a lot of trouble. I'm having trouble getting this prescription. I've already done many different options for treatments, and I'm just really not getting anywhere with my insurer. So we had started the groundswell across the states. We then introduced the Safe Step Act in 2017. And just like everyone in the room here has been talking, things can go very slow in Congress. And so this has had to be introduced several times in order, to be where we're at today. You're like, okay, Michelle, you're talking about, some people having trouble getting their prescription. So what exactly is in these step therapy reform acts? So really what it does is it ensures that there is a clear and transparent process. Things go quicker, and the doctor can ask for exceptions. So now, let's say if my husband would change insurance, new insurance says, hey, you know what? Let's have Michael try prescription A, and we'd be like, okay, well, if you look in his medical chart, he's already tried that one. He's already failed on it. Let's make this process quicker. Let's make it easier. So that's exactly what this type of legislation would do. It's already been successful in over 30 states at the state level, but we know that insurance is complicated, and the insurance at the state level is much different than what many of us have. So at the state level, you have state employee plans. Some of these bills also cover Medicaid. But for the rest of us, we're on employer-sponsored plans, so we're actually not covered by those protections. So that's why it's really important that we introduce, because we're still relatively early in this session, so we have not had the Safe Step Act reintroduced yet. So that's going to be your charge, is really saying, hey, let's reintroduce this. Let's encourage your fellow legislators to then be co-sponsors. So as you can see here, I just did a slight history of the Safe Step. It was first introduced in 2017. The companion bill in the Senate was actually not around until 2019. Last session, I kind of spoiled this at the beginning, but Safe Step Act had, way over half of Congress as co-sponsors. So let's keep on the momentum. Let's keep this up. I was actually just doing a training with one of our ambassadors last week, and she was sharing her personal story. And so similarly to my husband, she had tried and failed a number of different medications for her eczema, finally finding one that worked for her. Great. She finally is on it. It was a little bit of a hard time getting that insurer to pay for it. And then guess what? She's a college student. Her parents switched insurance. And that new insurance company, guess what they said to her? You gotta go through the steps again. And she actually has evidence in her medical record that those past medications worsen her eczema. So it has been such an ordeal for her. That's one story. Who in the room here, just thinking about this, who has gone through some type of step therapy? That is telling. Like, that is most of us. We have gone through something. And we've done studies at MIA. We have research that we do. And we've had, we did a recent survey. Over 50% of those surveyed had some type of delay or denial, with the majority of it being step therapy related. So we know this is a problem. This is our solution. It's common sense. All of our bills that we work on are bipartisan. So bipartisan, that's one of those terms. It means it has that support of both Democrat and Republican. So this resonates. I told my congressman about 1.5 years ago, he is a former judge. I said, Congressman, will you sponsor, be a co-sponsor of the Safe Step Act? I said, well, Sean, tell me a little bit more about it. So I was telling him a little bit more about it. And he said, oh, well, when I was a judge, I worked with patients that had to go in, like they had to do mental health inpatient care. And he's like, I remember that they would get on certain medication and they would do really well. And then once they were out of inpatient care, their insurance wouldn't allow them to stay on that medication. He's like, I see how this is wrong. And he became a co-sponsor. So our advocacy works. All right. So the bottom line, mentioned this term a couple times, but this is a bipartisan effort. 200 patient and provider advocacy organizations support this. We're just, I know Kelly said, we're 30 organizations in this room. So think about that number. So issues, arthritis, heart, cancer, diabetes, psoriasis is in the room. All the different ones. We're all doing this together. So our ask for you on the Hill tomorrow is to work, ask your legislators to make sure that we can introduce and pass the Safe Step Act. So with that, I think we're probably gonna go to the next one, but just as Soapbox will tell us later, if you've already looked at your schedules, you will see if they've been a previous Safe Step co-sponsor. You'll see if they were a previous HELP co-sponsor. You'll even see if it says new, and you'll be like, what does new mean? We have a lot of legislators that this is their very first session in Washington, D.C. So you can go to them and say, you know what, we really want your support, and this is why. So thank you for your time.
A really good overview, very helpful. And just so you all know, we're going to have time for you when you meet with your state group to talk about these issues a little bit more and you know, share your stories together, find out who makes sense to say what, who has certain experiences, et cetera, et cetera. So like Michelle said too, and if you all just check yourself and ask, what is it that really connects you to the issue? It was Michelle's story about her husband, right? So it's the same with all of us. When we share our personal stories, that's what sticks. We are the end user of the healthcare system. So it's really important that these legislators hear how it is affecting us instead of hearing from just the payers. If just the insurers show up, they're like, oh yeah, this is causing a lot of, you know, benefits to our health system by cutting costs. Well, if that's the only story they hear, of course they would go for that, right? But if they see how it's affecting us, they may change their mind. So next, I want to introduce Dr. Mark Kaufman. He is the Chief Medical Officer of Dermatology, or Advanced Dermatology and Cosmetic Surgery. He's also the past president of the American Academy of Dermatology. So we have a really amazing guy coming to speak to us today about PBM reform. I have heard him speak on this 2 times now, and every time I am so fired up and I learned something. And then when we were having our meeting about, because he's also going to be presenting at our congressional briefing about this to staffers, he was saying, oh, I had to change all my slides up today because of what's happening on the Hill right now as we speak. So this is a super compelling issue. Our hope was, in putting together the content for the briefing, is to provide information that these staffers are really hungry for. And what better timing to be presenting this right now? I have a feeling we're going to draw a lot of people into the room. So I'm going to, without further ado, hand it over to you, Dr. Kaufman, and take it away.
Thank you, Kelly. So it's kind of interesting because everything you've heard so far this morning is rooted in what I'm going to be talking about now, and I'll even show you where. You heard how important you are, and I can tell you, having gone to the Hill for the last 17 years with a bunch of dermatologists, they don't want to hear from us anymore. They want to hear from patients. And you guys really have the power. And so it's great that you guys are all doing this because it's really important. We're going to keep doing it, just nagging them. But we go as 40 different medical specialties, and that's another problem for another day. But anyway, I'm going to talk about why do medications cost so much. And all of you know some of this already, but some of this will be eye-opening, infuriating, and will hopefully incentivize you to go up tomorrow and really speak to your congressman and show them the impact that this stuff has. This diagram that you see on the screen is a typical commercial transaction in the United States, right? A company makes a product, it sells the product for a profit, and an end user gets what they wanted. Here it's a bottle of Pepsi, right? And everybody's happy because it's a simple capitalist interaction. So if this is a typical commercial interaction in the United States, why is this the typical prescription commercial interaction in the United States? It is extraordinarily convoluted, and it all comes down to that little green man in the bottom left of your screen. And that little green man is the pharmacy benefit manager. So what is a pharmacy benefit manager? Originally, they were created for a good purpose. They were created to try and negotiate price lowering by the pharmaceutical companies to be able to get the drug for the insurance company and deliver it to the patient at a lower price. That was the reason that they were created. But what happened was they started to do other things. They started to talk about what drugs to cover and which ones to force the patients to pay a larger share for, and all of a sudden their reason for being was no longer to just get lower prices for drugs. This is from 7 years ago. Talks about 3 companies, CVS, Caremark, Express Scripts, and OptumRx, that they controlled 72% of the US market, meaning that 72% of prescriptions written were processed through those 3 companies. Today, 7 years later, it's over 80%. Over 80% of prescriptions written today are processed by those 3 companies. Express Scripts, CVS, Caremark, OptumRx. You'll hear me tell you this a lot of times today. Because what happened over the last 5 years is that each of those companies were either merged, bought, or sold to a health insurance company. So CVS Health and Aetna merged, Cigna bought Express Scripts, and Optum was so successful that United Healthcare took the Optum CEO and made him the CEO of United Healthcare. Now, just as an aside, he wanted to be the chief operating officer, so he resigned after a year, and they hired a new guy who was just shot about 8 months ago. And now they're actually 2 CEOs later, because United Healthcare actually is in a bit of trouble, and I'll explain to you why in a little bit as well. This is from the Journal of the American Medical Association about a year ago. It talks about over the last decade, they found that CVS Health, United Healthcare, and Cigna constitute the 4th, 5th, and 13th largest companies in the United States by revenue. Okay, remember growing up, you always heard about Ford, GM, Exxon, all of these companies that everyone grew up hearing about as the largest companies in the United States. Now, 3 of the largest companies in the United States are health insurance companies. And now they're buying physicians. They're buying physician practices. 1 in 10 clinician that all of us see in the United States is employed by United Healthcare or by Optum, its subsidiary, that's a PPO. 1 in 10, 10% of physicians. This is a vertical integration that they have attempted and are trying to complete, where the health insurance company controls the PBM because they own them. They control the specialty pharmacy, and they control the provider services. If you get all this done, the entire supply chain of healthcare is controlled pretty much by 3 companies in the United States. If the numbers I told you, 4th, 5th, and 13th, aren't that impactful, this is United Healthcare, and you can see United Health Group is larger in revenue than Berkshire Hathaway, which I'm sure you've heard of, than Alphabet, which is Google. They're bigger than Google. They may not be, they've had a pretty rough week on the stock market, but they were bigger than Google. And these are the physician practices that they bought over the last 15 years. And so what happened recently that got them into trouble is they fired about 524 employees. Many of them were physicians and APPs. So why did they fire the doctors that they bought? They fired them because they told them that they wanted them to start padding the bills and adding, not procedures, but adding diagnoses to their claims by saying a patient with back pain might have kidney disease and put down kidney disease and do all these things that were unethical. Why? Because Medicare Advantage pays you more based on the level of sickness of the patient. And so they wanted their clinicians to basically exaggerate their patients' problems in order to get more money from the government. And the ones that didn't want to play ball because they were ethical and they said, I can't do that, they were fired. Well, fortunately, some of those fired physicians became whistleblowers. And they actually blew the whistle on United Healthcare and said that they are basically committing fraud. And what happens when you do a whistleblower lawsuit, also known as Ketan lawsuits, is the Department of Justice has the option to join or abstain from the lawsuit. Well, apparently now the DOJ has actually decided to join the lawsuit, which now makes the lawsuit a lot more powerful. And they have actually started investigating United Healthcare for their practices. And so this is good news. PBM strategies, what do? Some of them you just heard about, right? There's copay accumulator cards, there's step edits, prior authorizations. They are responsible for everything that you've heard of this morning, but so much more, okay? And I'm gonna just talk about 2 of these to drive it home, and these haven't been mentioned yet. So one of them was that their reason for being was supposed to be to go to the drug maker and get a better price for their patient.
At the end. So Kevin, go ahead and take
You
it.
got it. All right. Hello, everybody. How are you? You look great out there practicing. We always like it when folks are practicing before we even speak, because the number one important thing you're doing tomorrow is sharing your story, because Kelly and Natalie and I can go up and share the right numbers, the right bill numbers, the right details. But it's not until you come with your stories and your geography that they're really listening. And we always say start with your geography, because they really are not listening until they hear 123 Main Street around the corner from Galway Elementary. Or for my folks from New York or Miami or Chicago, remember not just I'm from Chicago, but I'm from 123 Main Street. Be very specific, because they want to help you if you're a constituent. So at any rate, it's always good for you to tell your story after your geography, because then they want to help you. That's how they remember you. So let me talk more about you. This slide shows that there are almost 80 of you, if not more by now, from 24 states, and you'll be conducting 103 meetings in just the span of a few hours tomorrow. 37 of those meetings will be with Republicans, 66 will be with Democrats. And I give that to you as background only. Remember, we don't talk about election politics when we are on the Hill. We don't talk about campaign contributions. We're in the legislative sphere. We invite everyone who is our members of Congress to help us. But I do think that's interesting to give that background. All right. How many of you all took a sneak peek at your schedule before you even came to Washington? Excellent. If you did not do that, not to worry. We're about to hand out your printed schedule, which will have the details of your mobile tool schedule right at the top. So some of the buttons I want to point out to you. When you first go in, by the way, it will ask for your cell number. The reason we ask for your cell number is so that tomorrow, when there are changes, we can text you with those changes. How many of you all have done this before? Great. And how many of you all, this is your first time? Wonderful. So those of you who have done this before, you know that Congress is in flux. They often move meetings up, they move them back. They might change a staffer on you. They might change the room. Sometimes they'll even have you walk the member to the elevator. So we want you to know about those changes before you go into the office. So we'll text you with those changes, but we do everything analog and digital. So we will also call one person from each group when there are changes. But back to the mobile tool. The most important button for you is that red button at the bottom. That is how you will have live assistance all day tomorrow. We have 10 people back in the office waiting to help you, so please use us. That's why we are there. So if you're in a long line at security, which can happen in the morning, in fact, they've been a little bit longer this year, but they do melt away by about 10:30, 11 o'clock, 11:30. But if you're in a long line at security, just call us. We'll call ahead to the office, let them know you're on your way. If they know you're on the campus, they'll hold your spot for you. But just give us a call, and if you're lost, call us. If you have a question before you go into a meeting, call us. Some other buttons that will be important to you. the bios of your members of Congress. In case you want to do a little research about your member of Congress before you go in, you can press the bio button. There's a button for the U.S. House district maps in case you want to see where your House district ends and the next one begins. There is a button for the map of Capitol Hill, which is right in the center, and I'll go over that in more detail when I show you the map of the hill. And then there are a few other buttons at the top in green. The Documents button. So Kelly and Natalie gave us several documents to load into the mobile tool that we want you to have the ability to read between your meetings, before your meetings. So anytime you'd like, just press on that. And then your team, those are the people you're going to your meetings with. So if you happen to be teamed with another state, you may have seen another state on your schedule, you should see that on your team. We do that so that no one has to go alone. And then your meetings in time order when you press your schedule. I'll go over into that in more detail when I show you the printed schedule. The most important part for Kelly and Natalie is the feedback portion of the mobile tool. So they brought you here to Washington. It's helpful for you to tell them how each meeting went. So after each meeting, we need at least one person, it can be all of you, but at least one person to push that megaphone icon under each meeting. You don't have to say who you are. You already logged in, so it knows that. You don't have to say which meeting you're talking about because you're pressing that bullhorn icon right under the meeting. You just need to answer the questions. I think there might be as many as 5 questions in there. So you answer those, and if the member of Congress pops in and you take a photo, please attach that to the feedback form. We love to get all of those photos. And even if it's a picture of you with a staffer or a picture with you outside of the office, go ahead and upload those because we love to collect those throughout the day. And then we at Soapbox send those to Kelly and Natalie so that they have those at the end of the day. All right, so the printed schedule. I mentioned that we do everything analog and digital. If you're over 50, like me, you might want some dependable technology called paper. Certainly what I like. So we're gonna hand that out to you in just a second. That's why you were seated at your states. You'll notice that your name and your district are on the upper right corner. Below that is our help desk number so that you have it right there on your paper schedule. And here's that mobile tool code. So the mobile tool is not an app. Just want to say that again. It's not an app. You don't have to download anything. I think most of you have already gone to the website, but just know you don't have to download anything. You go to the website so that you can use it on your desktop, your laptop, or your smartphone. And then the code is right there so that you can put that in and see your meetings in real time. Below the help desk is your team, the people that you're going to your meetings with, and then the meetings in time order. If it says with member, you are on the schedule of the member of Congress. If it has a staffer's name and title, that is the person you will ask for when you arrive. We put their titles right after their name, and then you look down at the bottom and you can see what their title stands for, or the abbreviation for their title stands for. So if it says COS, you can look down at the bottom and you'll see that's Chief of Staff. LA is that Legislative Assistant. So we want you to know what their titles are down there. And then we put the building and the room number, which you can flip over the back of your printed schedule and you'll see the map so you know where you're going. But the abbreviations for the buildings are right down there. So if it says SD 123, you look at the bottom, Senate Dirksen 123. Again, I'll show you the map in just a second. And then we put a few things on here that will help you know more about your member of Congress before you go in. You all have told us over the years that you like to look at your schedule at a glance and see if your member of Congress has done something for us, or they might be more important perhaps because they're on a key committee. So we have tracked if your member of Congress is on one of our key committees. If you're a newbie to this, don't worry about key committees right now. It simply means that they take up our legislation. That's important for us. So we want you to know that that member of Congress is on one of our key committees. If it says up, that is a senator who's up for re-election in the next cycle. If it says new, that is a new member of Congress. If it says RET, that's a member who's retiring. And I think there's one that says Health Pro, so that you know if it's a doctor or a nurse. But we've even tracked more for you. Because we're talking about the Health Co-Pays Act and the Safe Step Act, we want you to know whether your member of Congress has already done that, has co-sponsored that. So I'm gonna pull out my glasses because like I said, I'm over 50, so I need to read. So if your member has co-sponsored the Help Co-Pays Act in this Congress, you will see Help Co-Pays Act in brackets on the same schedule line. And you can say, thank you. Yes, and watch them light up when you thank them for doing something. Not many people do that. So we want to go in and thank them for doing something for us. If you see PREVE Help Co-Pays Act, PREVE stands for Previous Congress. So that would mean that your member of Congress co-sponsored the Help Co-Pays Act in the previous Congress. Again, PREVE Help Co-Pays Act. If you see PREVE Safe Step Act, that means your member of Congress co-sponsored the Safe Step Act in the previous Congress. And finally, if they signed our Dear Colleague letter that I think you've been hearing about already, but maybe you'll hear about it later, it will say LTR on the same schedule line so that you know your member of Congress has signed our Dear Colleague letter. All right, so when you flip the schedule over on the map, or excuse me, on the back side, you will see the map. The Senate office buildings are 1 block north of the Capitol, and they're all right in a row. So it's Dirksen, Russell, Hart, all connected by basement hallways. I mention the basement hallways for a couple of reasons. One, once you go through security in one of those buildings, you don't want to have to go back outside and go through security again. That will take more time. So just go down to the basement and over, and that way you'll get there more quickly. We've asked for each of your meetings to be 1 hour apart. If you notice 30 minutes between meetings, you'll notice it's on the same side of the Capitol. So you're going from a Senate meeting to a Senate meeting or a House meeting to a House meeting. You will have time for that. You can always start your first meeting with, I have a meeting on the half hour. We're happy to keep this to 20 to 25 minutes. They will find that very gracious, and they will be happy to oblige. But the backup plan will be you'll call our help desk if you're running late. Some other things I want to point out about the map. There are shaded blue boxes to tell you where the entrances are to these buildings. So if you go up there and there's a long line at security, you could send someone around the corner to see if the line is shorter at the next entrance. We've also marked the accessible entrances, and we've marked if there's food and coffee in the building. And then most importantly to you tomorrow, I think, will be the estimated walking times between the buildings so you know how long it takes to get from one to the other. So most of you have your Senate meetings in the morning and your House meetings in the afternoon. At least that's what we've asked for. Of course, if Congress or one of the members of Congress needs to have the Senate meeting in the afternoon or the House member needs to have theirs in the morning, we always say yes so that we can get you into that office. But most of you have the Senate in the morning and the House in the afternoon. So when you go from the Senate side to the House office buildings, which are a block south of the Capitol, again, Senate is 1 block north, House 1 block south, it's about a 15 to 20 minute walk from the Senate side to the House side. Most people like to walk it because you're going by the Supreme Court and the Library of Congress, so it's very cool to walk by those two things, and I hear it's going to be, I think it's going to be a beautiful day tomorrow, if I've heard the weather correctly. If you want to take a cab or an Uber, that's no problem. People do that all the time. So feel free if you want to do that, you can. Couple of tips. The first one might seem obvious. You're establishing and building relationships, so no threats, insults, or shaming. Sometimes people think that when they go in, they will have maybe a disagreement with a staffer or a member of Congress, because sometimes you see that in the electoral sphere or on the news. When you're in these legislative offices, they want to help you. They want you to go away happy, so that won't happen. So we're building relationships, and remember that the staff is just as important as the member of Congress, because the person who answers the phone when you call and the person who replies to your email is the staffer. So when you follow up and say, hey, did the member say that he or she would co-sponsor the Safe Step Act? It's going to be the staffer who replies to you. So we definitely want to respect our staff members. They're just as important. Video and audio recording. So in each case, we have not gotten permission for recording a meeting. So make sure we don't pull out our camera and record it, or even audio record it for our own notes. You'll notice that they shut down if we're recording something. But still photos are great. Never a problem, you just ask, can we take a photo? They're always happy to do that. And these meetings have official rosters. So why do I say that? So we've given each office exactly who's coming to your meetings. You'll notice that sometimes they even greet you by name because they've got your names there and they know you're coming. So the only mistake we can make tomorrow is to not show for a meeting, right? So if a member came back from a fundraiser to meet you because you're a constituent, and then the constituent's not there, they will remember us for the wrong reasons. So it's never a problem to tell us ahead of time if you've got an emergency, you're sick, you're getting tired by the end of the day, just call our help desk so we can call the office and let them know. And sometimes people think, well, even though the constituent is leaving, we're from the state, so we'll just go. You can go, but we want to give them a heads up so that they know you're coming in place of the constituent. So just call us ahead of time and let us know if you can't make a meeting, or you can see us outside of the help desk if you already know that, because we're going to be right outside of this room right after we hand these schedules. All right, so my last slide, and then I'm going to answer any questions you have. So I mentioned you're seated by state. So we're going to hand out large white envelopes by state. So we need one person from each state to pull those individual schedules out of the envelope. Remember, the names and the districts are on the upper right corner. If there are any unclaimed schedules, that's the most important part to Kelly and Natalie's relationships on the Hill and our relationships on the Hill. Please put those back in the envelope. So any unclaimed schedules go back in that white envelope. If there's somebody here who didn't get a schedule, just put your business card in the envelope, or if you don't have a business card, write your name, address, and cell phone number on the outside of the envelope. And then that one person will bring that envelope to us at the help desk. Most of you will be returning an empty envelope, and you'll ask, well, why am I returning an empty envelope? You'll notice there's a little place on the outside that has a name and a number spot. So we just need one person to write their name and number. That is the person we will call tomorrow with changes. So I mentioned we'll text you, but then we'll also do old school. If you don't use your phone for everything, just for phone calls, we'll call one person that's written on the outside of that envelope. And then you can come to us with any questions, comments, or needs. Most people send that one person out with all the questions from your state. That usually works well, but if you want to come out yourself, that's perfectly fine. You can come out to our help desk and we'll answer any questions. Speaking of questions, what do you have for me? Yes, ma'am.
If there was a break in our scheduled meetings, are we allowed to, I know you said there's a roster, so we're not allowed to like go join another group? Or we
Join another group. So she said, can we, if we have a break in our schedule, join another group? So we want you to follow your schedule exactly as it is because we've given accurate rosters. However, you can see us at the help desk and we can look at that, and we can certainly today alert an office if you're coming. So just see us at the help desk afterwards and we'll take a look at that and give a heads up to an office if you want to go along with some other group. But we do want it to be within the state if possible. You just brought up something that reminded me. So some of you might have noticed the word drop off instead of a time on your schedule. If you see drop off, it probably says awaiting confirmed time at the end of the schedule line. Some offices, believe it or not, get back to us on the day before to confirm a time. So you will notice on the mobile tool that a time pops in there once we hear from that office. If you don't see a time pop in there, you can call our help desk. And finally, I want to mention, if you have flown here or driven here, and you see drop-off, awaiting confirmed time, or drop-off, office says unavailable, you definitely want to go into that office. You're a constituent. Don't be intimidated by that. You can go in and you can say, hi, I'm Kevin Schultz. I'm from Lexington, Maryland. I'm a constituent. I understand no one could meet with me today. Is there someone who can come out and shake my hand and take my folders since I drove here from Lexington? It's always okay if we're polite and we say that. And in fact, if we're just a little louder than we might normally be, the member of Congress or the chief of staff sometimes hears that, and they will come out and they will meet with you. We've had several instances where those drop-offs turns into meetings. I even had one group have a tour of the Capitol by going in and saying that. So be sure to say that if you see drop-off. What else do you have for me? Yes, ma'am.
I was trying to look up the app on my phone and I couldn't find it. Do you have a QR code where we can download the app?
No, it's a website, so we're going to help you with that because when we hand out your printed schedule in just a minute, you should see your name and then the code right to the left of that. If you don't, come and see us at the help desk, but everyone has a code on their printed schedule that we're about to hand out.
And the URL is also printed on there?
Thank you for saying that, yes. Let me just show that again so that you all know where to look. So here's your name and your district. Here's your unique code. So you go to sboxmobile.com, that's the website, and then you put in your own unique code and you'll be able to see your schedule in real time. So you'll see the changes happen as the offices call us. What else do you have for me?
No question.
Wow. That's quite a group. All right. Well, we're going to hand out your schedules now. And before we do go, do you have any final announcements?
I'll just say that it's the team leader from the States that will go and get the schedules from the help desk from Soapbox and then bring it back to your table, open it up like Kevin was saying. If there's anyone who didn't show from your group and, you know, so you have the schedule that that person is not there, you're going to put it back in the envelope and give it back. And then they also have a folder for you that has like the leave behinds. They will give you once you hand that envelope into them. And I just wanted to make one last comment too, because we haven't said it yet, but it was alluded to that a lot of these staffers are under a ton of pressure right now. There's so much going on and they're really stressed out. So let's be a breath of fresh air. When we go into those offices and be encouraging, thanking them, you know, building them up for the service that they give to all of us. They're amazing people. So I just wanted to make that point too. To be really mindful and intentional about that.
Such a good point. And I've got good news. You don't have to go out to get your schedule because we are about to hand them out. So you will just sit there and we will bring your schedules to you. But Kelly's absolutely right. You will bring that empty envelope or the envelope with the unclaimed schedules back to us with any questions. All right. Well, thank you so much for inviting us to be a part of this event. I wish you the best of luck tomorrow. Thank you. Thank you.
Right? But what happens is PBMs group arms like an octopus, and they have their hands everywhere. And so they decided to put their hands in the pharmacy and get involved with this interaction that was pretty simple, a straightforward commercial interaction in the United States. They buy the bottle for $1.60 for a medication, they sell it for $4, they get a profit. Again, everybody's happy, right? So what did they do? They put themselves right in the middle of that. And they said, no, that's not going to work for us. Instead, you're going to buy the bottle for the same price. You're going to charge the patient $11. We're going to give you less profit than you got when you sold directly to the patient, and we're going to just take $9 because we are a PBM. Okay, and this was the way it was until Trump's first term. And then I put the picture up actually to talk about the other guy, Alex Azar. He was the HHS secretary in Trump's first term. And before he was HHS secretary, Alex Azar was president of the Eli Lilly. So he knew exactly what was going on. And he actually came up with a brilliant design plan to blow up the PBMs. The first thing they did was they actually passed the Patient Right to Know Drug Prices Act, and Trump signed this into law in October of 18. Because until October of 2018, your pharmacist was prohibited from telling you that if you paid for this product in cash, you would pay less than with your insurance, because the insurance was padded with the PBM product. They had these clauses in their contracts. So in October of 18, they got rid of that. And now we'll talk about rebates. And these are not the rebate cards that you've used or that you've heard of today. This is a euphemism for kickbacks. Okay, so again, PBM is supposed to interact on the benefit of the patient, but what they do, in essence, is they tell the insurance company, if you want this thing to be on your formulary in a favorable place, you have to make the rebate that you give us for no good reason, except that they're there, you have to give them a higher price, right? You have to give them a higher rebate. And basically they're selling formulary placement to the pharmaceutical companies. The more they give them, the higher the placement on the formulary.
Dr. Kaufman, can
Yes.
you explain what a formulary is for people
Okay,
who
so
might-
formulary is on an insurance company, there's formulary that is basically what is covered at what tier, right? If it's level 1, it's got the most favorable copay. You know, if it's a level 2 or level 3, they're higher copays. And so they were selling basically placement on the formulary to the pharmaceutical companies, because if the pharmaceutical company got placed at the lowest or highest tier, the copay would become very difficult for the patient to pay. And so some of them wouldn't even get placed on the formulary if the PBMs didn't like what they were getting back. And so this was the way that they operate. And this is the way they can operate because of a law that actually protects the PBMs. The PBMs in 2003, for some reason, and nobody actually knows who slept with who to get this, but they were given a Stark exemption. The Stark law is the law that all of us in healthcare basically have to operate under, which is we cannot refer anybody or make money on a healthcare transaction. Right? A doctor can't say, I'm going to refer you to this doctor and then get a kickback from the doctor. It's basically the anti-kickback statute. It means that nobody is doing stuff in healthcare that results in kickbacks in any direction. And everyone in healthcare is subject to this rule, whether it's a hospital, a physician, everyone. You know who's not? PBMs. PBMs have an exemption to the Stark law, okay? I don't like to speak ill of the dead, and if you don't know who this is, it's John Gotti. He's no longer with us, but he was one of the mob bosses in New York. And if he were still alive, he would be in his cell, hitting his head against the wall thinking, why didn't I think of this? Why? Because the PBMs are doing exactly what John Gotti did, right? They are getting their vig from the pharmaceutical companies. But they have a law that protects them from having to tell anyone what they're doing. Okay? You can't make this up. It is the perfect crime that they are committing. So what was the plan that Azar came up with? Azar's plan was to remove the Stark exemption from those companies, from the PBMs, and instead give it to the patients. So the patients could get a discount at the pharmacy and it wouldn't be considered a kickback. But the PBMs would no longer have an exemption that allows them to do this without anybody seeing. Because the answer to all the problems that the PBMs make is one word: transparency. If there was transparency of what they were doing, then no one would stand for this. The scrutiny would be insane, and there would be no way they could get away with this. But they are protected by law that they don't have to be transparent. And that's the problem. So he tried, and he put this through, and he put a rule through, and it was ready to roll. And then at the last minute, this was during Trump's first term, his political advisors went to him and said, we've been told that Part D premiums are going to go up if you sign this into law. And so he dropped it at the last minute, Trump, because he was afraid of losing the elderly vote in his reelection campaign. And so there was a press conference, and Azar said, you know, at the end of the day, tail between his legs, while we support the concept of getting rid of rebates, we're not going to put seniors at risk of their premiums going up, he said. And he contended that rebates days are numbered. They weren't. And then finally, the decision drew praise from the pharmacy benefit managers who would have been most hurt by the proposal and who had lobbied members of the Domestic Policy Council and top health officials to drop it. And this is what happens every late October, early November, before Election Day. And that's why you heard already today a few times that things need to be reintroduced every 2 years. I'm going to go into this more tomorrow. But basically, this is what happens every year. We go down there, everyone's talking about PBMs. In this big, beautiful bill that's being debated right now in Congress, and it's going to be voted on later this week, there's a PBM provision in there. The last time there was a PBM provision in one of these omnibus bills at the end of a year, this was at the end of 2023, the House put in their PBM transparency bill, and the Senate said we're only going to sign on if you take that out. So when you go to the Hill tomorrow, you can thank the Congress people for putting the PBM thing in there, but tell them that that's not enough. It's got to stay in there. Because when it goes to the Senate, there may be enough people in there that say, we're going to sign it, but you got to pull that out. And sometimes these things, and this bill is humongous, right? This is going to be the amount of dollars that are going to be in this bill are going to be beyond anyone's comprehension. And so there's going to be bartering and trading and horse trading that goes on between the House and the Senate. This is the one thing that every year usually gets traded off. And you've got to start telling your Congress people that you know what's going on. And they're all going to say, yeah, we know we got to get transparency for the PBMs. They've known that for years. They've known it for at least 5 years, probably more. But when it comes to having contributions to their campaigns, you know, they do what they got to do. But if we go in and we are pissed off enough, then hopefully they will listen to us. And this is, I'm just going to end with this. This is from the executive order from last week. We're going to cut out the middlemen and facilitate the direct sale of drugs at the most favored nation price directly to the American citizen. You gotta hold Trump to that, you gotta hold Congress to that, and the Senate. And the Senate is almost more important than Congress, because Congress put it in the bill. They're gonna probably vote it out. The Senate is gonna be the ones that have the power to take it out. So I would concentrate tomorrow on your senators and tell them the House is gonna send you something. Don't take out the PBM part. Thank you.
Yes.
So you yourselves are constituents?
Yes, we live in your state. We live in New Hampshire. I forget where you said you were from,
Oh, I
but
said I
I'm
was
from
from
New Hampshire.
California, but that's okay. For the sake of this exercise, I'm now from the good state
Yes.
of New Hampshire.
Yes.
Yeah. How are things going in New Brunswick?
Excellent, excellent.
Oh, very good to be here. And so I'm so glad that you brought your daughter with us today here. It looks like she's a little shy, but that's okay. You know, tell us about yourself. Why are you here today?
Do you want to go first, or should I go first? Okay, I'll go first. So this is Lee J. She's 7. She has alopecia. We're here today with the Coalition for Skin Diseases. Do you know anybody with the skin disease? Anyone in your family or any of your friends?
Oh, well, it's interesting you should ask that. As a matter of fact, yes, on my wife's side of our family, we do have someone who has eczema. So it's interesting. Does your daughter herself have a skin disease?
She has an autoimmune disease, alopecia. And I'm not surprised you have a connection, because 84 million people have a skin disease in the United States. So I was anticipating you had some connection to it.
I didn't realize it was that many.
Yeah, so we're here today with CSD, and like I said, Lee J has alopecia. When she was 2, she was first diagnosed with alopecia. She started to lose all of her hair, and we were just searching for answers. We were Googling what could be happening to our little daughter. We were Googling treatments. We were Googling solutions, and I think you probably know that that's not a good, healthy thing to do. So we ended up talking to her doctors, doing some research. We found NAF. NAF is the National Alopecia Areata Foundation, and for us that was really like, that solved all of our problems as much as they could be solved. So we learned about the best treatments that could be available. We found a community, and so for Lee J, who had never seen another person or another kid without hair, that was a really meaningful opportunity for Lee J to. And she joined a different organization, Confidence Club.
Oh.
Yeah. And so she was able to see other kids and people online. That was a great experience. So what NAF did was it gave us a community, it gave us information on the best treatments, and it gave us education. And so that leads me to sort of our asks for today. So all of those things that we want to see, transparency in the medical process, research, a community, education. I don't know these off the top of my head, so I'm going to pull out our one-pager, which you'll have a copy when we leave today.
Oh, I see.
We would really ask you to support robust funding for a number of different agencies. So CDC, NIH, SciAMS, and other organizations. We would ask that you strongly support robust funding for those agencies and initiatives. And we also would ask for you to co-sponsor the legislation that's referenced in your packet, because if we can, through you, advance those programs and that funding, I know that not just for Lee J and the future support and the treatments that can be available to her, but for the 84 million people living with skin conditions, they would appreciate your support.
Well, this is all really good information, Tori, and I appreciate you sharing it with me. Just where are we right now with treatments for alopecia?
So there are a number of treatments available, but they come with pluses and minuses. And our hope is that through the research that we're asking you to support, more treatments can become available that can be quicker, that can maybe have fewer side effects and be available to more people. So that's sort of where we want to go with this funding.
This is all really good to know. Well, I appreciate you coming in here today and giving me this information. Lee J, thank you as well for taking the time to come in with your father.
Do you have anything you want to say? No? What if you had a microphone and a stage? No. Well, there's one more thing, Senator, we'd like to ask. If we can get a photo, we'd love to share it on social media just to show your support for CSD.
Oh,
Yes, it is.
About that. Yes, of course, we have a place here in the office, we'll do that. Well, thank you so much for coming in today.
Thank you for your time.
Appreciate it. Let's do another hand for Tori. Will that work? Okay, all right. So we're going to let her rip here. I am now a senator from Georgia. For those of you who are keeping score, I was originally in California, then I moved to New Hampshire, and now I reside in Georgia. And again, I'm very popular. This is like my 7th term now. And I welcome these 3 advocates. We're just sitting down in my not-so-palatial office here in DC. And let's let it rip. First one of you. Thank you so much for joining me today. It's so wonderful to see constituents. Now, who here is from the state of Georgia amongst you? Oh, wonderful, terrific. Well, how are things going in Savannah? That's where I'm from. Are any of you from Savannah?
A little humid, a little hot.
A little humid. Oh, what a change.
It's such a beautiful city. I love the history there, the architecture.
Oh, well, it's great to see you, my constituents, and yeah. Well, what brings you here today?
So I want to start off with reinforcing the Safe Step Act. I have hidradenitis suppurativa. I don't know if you're familiar with that, but you have boil-like abscesses that happen around your hair follicles. So you can be affected anywhere between your armpits, your groin area, even your arms. Anywhere that there's a hair follicle, it can be affected by it. But with the Safe Step Act, it's enforcing us to go through a series of medications in order to get a medication that actually works. And I've been through at least about 5 in the past 3 years, and I have not had any help with it. So we're looking for funding to go towards that act, so that way I'm able to switch insurances effectively without having to go through all those steps in order to find a cure or help for my condition.
Okay, and this is called step therapy?
It's called the Safe Step Act.
Oh, the Safe Step Act,
Mhm.
okay.
Yeah, it helps with, I mean, a lot of like, it's an uncurable skin condition, and there's no one treatment that works for everybody, and it's a condition that it's probably a lot more common than people talk about, and there's a good chance you know somebody that has it, but they just don't talk about it because of the nature of the condition and where it affects, like, you know, you look at our faces and you're like, oh, you don't have a skin condition, you know, but it's like underneath, and so so yeah, a lot of us, we have to try many different medications, and sometimes our insurance will cover the medication that our doctor prescribed, and so the Safe Step Act creates an exemption for that. So we can work with our doctors to make sure that we're getting the right treatment the first time. And so if you co-sponsor that bill, it would be really helpful.
Oh, okay. See where that's important.
Now, like my colleagues, I also have an uncurable skin condition. And I know you mentioned Savannah. Have you ever been to a Savannah Bananas game?
Oh, as a matter of fact, yes. Last time I was in the district, I threw out the first pitch.
I do love those banana bananas. That's amazing. So, like my colleagues, I mentioned I have an uncurable condition. Have you ever heard of lichen sclerosis before?
I can't say that I have. What is that?
Well, lichen sclerosis is a condition. It's an autoimmune condition, and it affects the skin of the genitals and the anal area. And don't worry, I did not bring pictures. I have saved us all from that. But I got diagnosed in 2021, and I had thought, oh, I just had a little manky feeling from working at home and sitting in a chair all day after a year into the pandemic, and it turns out my gynecologist took a look and diagnosed me on site, and then confirmed it with a biopsy, which is just as awful as you could imagine in that area. I also have access to my childhood medical records. My dad was in the Air Force, and God bless the military and their rigorous record keeping, because I have a folder, and I discovered I had actually been diagnosed when I was 4, and then had been untreated for over 40 years. And I'm very lucky, because lichen sclerosis affects about 1 in 300 women, and men can also get it, but women are 2 to 3 times more likely to have it. It causes a lot of issues, as you might imagine, itching, tearing, fissures, fusing of different parts of the skin. Now, I've responded well to treatment. The good news is high-potency steroid is recommended. I was able to get on that right away. I responded well to it, but I also, within a few months of being diagnosed, joined up with a group of other women, and we founded the Lichen Sclerosis Support Network. And we're a nonprofit dedicated to patient advocacy. And we work to also educate providers in the medical field, because some of them are not great at identifying it. And what we'd like to do is ask for your support in funding robustly the NIH. In particular, because while I responded well to the treatment, I know from my experience with LSSN, not a lot of women do, and they need to find different treatments, and there's not a lot available. And so we think with funding for the NIH, we might be able to discover more treatments and have more options available.
Pam for president.
And Savannah Bananas reference.
And well, my own father also was an Air Force officer, so that's very interesting that you brought that
Well,
up.
thank him for his service, please.
For your father's service. So really interesting to hear all of this. Well, you know, let me see what I can do here. Just out of curiosity, you two were telling me about something called the Safe Step Act. And do you know, has there been a CBO score for that yet?
I don't have that information on the top of my head, but I can follow up and send you an email with that information if you like, and it's also going to be in the packet that we're giving you.
Oh,
which you can
okay.
reference.
Fantastic.
So it's an imaginary packet.
And I will imaginarily accept it.
Here's a funding report.
Oh, wonderful. This is tremendous. Well, I appreciate you giving me all this information here. And again, thank you so much for coming in today.
Absolutely. Can we take a picture with you, please?
Yes, of course. Let's go do that.
Scoliosis, and I was born with it. So all of my life, I've never had any type of, well, there's no cure for it, but the medication that I've used something that has really worked, and it has not been federally funded. So I went through clinical trials, and it worked really well. But after the trial, then I didn't have access to it. And so, and I'm not sure exactly why it doesn't go through the federal funding, but that is something that I'm really passionate about, because it would be something that would just make my life much more manageable.
Okay, all right. Do you know, like, has there been federal funding, like, towards, like, treatments, or are they doing research into cure?
Well, there's a lot of research, but that's where it stops. It's just, I mean, the research is being done, but then the medication is not approved, so it stops there.
Oh, okay, all right.
I'm Alyssa. I'm with a nonprofit called Mucus Outreach, and we support people with congenital melanocytic nevi.
Can you tell me about that? I'm not sure what that is.
Congenital melanocytic nevi is basically just birthmarks you're born with. They can present differently on different people, so you can have small ones, large ones, giant ones. My son was born with a giant one that covers his entire back. And you can also have related conditions where it's also in your brain and spine. Something I'd like to share with you is my experience. I journaled a lot in the beginning of our journey, and I would like to share with you a couple of those journal entries condensed down so you can hear my experience. 1 in 500,000. The number on repeat in my head. How are we 1 in 500,000? The first week of Jace's life was a blur. What was supposed to be one of the best days of our life turned into one of the most painful. Jace's delivery was much like my previous 3. Quick, uneventful, and exciting. That was until they placed him on my chest. Within a few seconds, he was whisked away as his nurse asked if I minded if she took him for a second, which didn't seem like a question, but more of a request. This was a little different than the previous 3 skin-to-skin deliveries I had experienced before, but I didn't think much of it. That was until my husband mentioned he had a large birthmark on his back. My eyes were glued to the warming table across the room as my doctor palpitated my stomach in attempts to deliver my placenta. I couldn't even focus on what was being done to me as I watched helplessly from the hospital bed at my son. One pediatrician came in and then an RN. I had not fully seen the extent of Jace's condition yet, as the only thing I had seen was his front side, and from there, he seemed normal. They turned Jace's back towards me. My stomach sank. A birthmark covered 9% of his back, with smaller ones scattered across his body. I remembered muttering, "Is that okay? Surely a birthmark that large couldn't be healthy." Everyone seemed so secretly nonchalant about what was happening that we didn't really think much of it. But knowing what I know now, I know they just were not educated about his condition. That night, my curiosity got the best of me, and I fell down the Google rabbit hole, having to diagnose my own child. A giant congenital melanocytic nevus, cancer, melanoma, seizures, mortality of 63%, death. The words blurred through tear-filled eyes. How am I supposed to care for a child I could see leave his life before me? I never experienced such extreme emotions in just a few short days. I was selfishly angry that the excitement of his birth of our first son was quickly overcome by anxiety, fear, and doubts. We spent an extra, unexpected 4 days in the hospital. I secretly felt a sense of peace having to stay a few extra days. To be honest, I was scared to take this child home. I was scared to be away from medical professionals that could help me if something went wrong. I was so uneducated about what was going on that I was afraid of my own child. We got Jace's skin diagnosis at birth, a giant congenital melanocytic nevus, a 2 to 5% increased risk for melanoma. We could handle that. Where things got complicated was if there was brain and spine involvement, a diagnosis that came with complicated risks and no cure. Jace had his first MRI at 3 weeks old. I remember the night my husband and I got the call with his results from our dermatologist very vividly. The silence on our end of the phone was so loud while she carefully explained all the complications that came with it. Seizures, hydrocephalus, central nervous system melanoma, the big scary word that had no cure. I was listening, but I couldn't process it. Deep down I knew Jace was going to have neurocutaneous melanocytosis, but part of me had hoped and prayed that maybe I was wrong. We hit our 3rd roller coaster exactly 3 weeks after that second diagnosis. Seizures. The things that gave me nightmares were happening. It seemed like we couldn't catch a break. Sometimes I find it hard to let my guard down, afraid of that roller coaster taking off again. The unknowns that come with this diseases are a lot. I feel like we're frolicking through a field of flowers, dodging landmines we can't see, trying to enjoy this new beautiful life while taking the blows of what this new life has handed us, trying to suppress our feelings of anxiety so we can live a normalized life for all of our other kids. Then came a light, and that light was a community of people just like me. Parents going through the same excruciating feelings that still to this day fill my body with trauma I can't explain. People with a passion as deep as mine to raise awareness, to educate, and most importantly, to advocate for all of us out there who are praying for a cure. Here at Nevus Outreach, we are building that bridge, but we can't do it alone. We need your support to amplify our mission. Through policy, funding, and recognition, together we can ensure that every child born with a rare condition like CMN and NCM, and every parent beside them is not met with silence, but with answers, compassion, and hope. Jace has taught us a lot about life, humbled us, made us sympathetic and kinder, made us stronger and wiser. And I no longer question why he was given to us. As much as I needed Jace, or as much as Jace needed us, we needed him. Jace is our 1 in 500,000.
very effective. Now I know what Nevis is.
You what?
Now I know what Nevis is.
Yes.
I did not know that before this meeting started, but you're giving me an education.
So.
And Brian, is it?
Yes, I'm Brian. I'm with the National Scleroderma Foundation. And I have, I don't know if you've heard of scleroderma or not.
I have not.
It's a rare disease, but it does affect almost 300,000 Americans. It can present itself very differently, and can, depending on the kind, the type, it can be fatal even. And what I think I've heard from my community over the last year, now from my new friends, is really what we're looking for is hope and education. And that's why we are really looking for support for robust funding for the NIH and for NIAMS and for the CDC and the CDC's Education Awareness Program, because we still have so much to learn about these various diseases and really all of the diseases that the Coalition for Skin Diseases are representing. There's a lot to learn, and that's why the research needs to continue. I've heard from my community, it feels like we've just started to make progress, and we don't want to see that progress stop. And that's really why we're asking for that continued support for those institutions and for that very, very important work.
Let me ask you all this. Do these three have anything to worry about tomorrow? Yeah, you guys are going to kill it. I thought that was fantastic. Let me